there is
Let
some
me check.
the screen.
Can you see now?
No, they are trying to adjust it just a few seconds.
Okay. Just let me know when you see my screen.
Yeah, of course.
So I can start.
Okay. We apologize for this. Just a few minutes.
No problems. No problems. Let me know if you want me to try to disconnect and share the screen and try again, or you do something. Can you see now my screen?
Now you can see.
Okay, great.
You can start. Thank you very much.
Thank you. I want to thank you for this great pleasure and great honor to be invited in such important meeting and scientific congress. And I want to thank the people who have organized this meeting and those who have invited me. So my name is Enrico Opocher. I'm a pediatric oncologist from Padova University Hospital, Italy. And I want to talk to you briefly about neurofibromatosis type 1 and nervous system tumor which are associated with this syndrome. So as you might know, neurofibromatosis type 1 or NF1 is a chronic disease, a genetic disease caused by genetic alteration and a mutation in the NF1 gene, which is associated with various and heterogeneous manifestation, which depends on age. So upon specific age, there are specific characteristic and phenotype of disease. So as an example, since very early, children may present with a classical café au lait spots, as well as presenting with bone abnormalities, and some of them present with congenital plexiform neurofibromas. So during infancy and early childhood, they might present with other complication, either scoliosis or skin or subcutaneous neurofibromas, leash nodules, and sometimes they present with learning difficulties or attention deficit hyperactivity disorder or autistic spectrum disorders, and other types of tumor, including optic pathway glioma. With progressive age, then into adulthood, then they can present with other types of tumors, as well as more cutaneous neurofibromas. And notably, they can present with also malignant type of tumor like sarcoma, breast cancer, and brain malignant glioma. So it's a very heterogeneous disease that differs by age. We know that the pathway is the gene alteration leads to the lack of this protein, which is called neurofibromin. And its role basically is an oncosuppressor. So when the gene causes lack of neurofibromin, there is a constitutive activation of this oncogenic pathway, which is called RAS-MAP-ERK pathway, which cause activation and cell growth in the tumor. And that confers the oncological risk of neurofibromatosis type 1. We know that there are various tumors associated, again, which differ based on age. Most frequent tumors are neurofibromas, as well as CNS tumors. But other tumors might occur, like hematologic tumors, like juvenile myelomonocytic leukemia, as well as other rare tumors. And you can see from this graph that some of the manifestation, again, have a peak at different ages. In terms of the peripheral nerve sheath tumors, there are different types of what we call neurofibromas. We have the subcutaneous neurofibromas, as well as the plexiform neurofibroma, which involves a more deep structure of the nerves and the vascular structure. They can have increased cellularity, and sometimes they are characterized by more aggressive features, which we then call atypical neurofibroma, or sometimes degenerate into more malignant features like sarcoma. Give me 1 second. I apologize. Sorry, I'm back. I was called by the phone. So there is a risk of degeneration into more malignant tumors. Plexiform neurofibromas are a common complication of NF1. They are, at the beginning, benign tumors that occur in about half of the patient with NF1. Sometimes they are diagnosed clinically because they present with a palpable mass. But sometimes there are more internal neurofibromas, which are only diagnosed if you perform an MRI. As we say, they grow along the nerves and the nerve branches below the skin, and they are composed of different types of tumor in like the Schwann cells, the mast cells, and the collagen cells. There are key factor and stepwise process which cause proliferation into plexiform neurofibromas, and the main driver of plexiform neurofibromas is the loss of NF1 gene and its consequence. But when they degenerate into more malignant tumors, they are characterized by progressive acquisition of other somatic mutation in the tumor. Neurofibroma can be difficult to classify because they are quite heterogeneous, and you can see they have various morphological structure, from diffuse to multinodular. It is, as you can see here in the arrows, they can be superficial or more deep located, and they can have different characteristics in terms of relation to adjacent structure and be circumscribed, as you can see here on the right, or be interdigitating and infiltrating in the structure, in the overall structure. Depending on the location, plexiform can present in virtually all the possible locations, and based on the location, they can present with different degrees of morbidity. So if they present in the neck or chest and an arm, they can present with significant disfigurement or focal motor deficit or sensitive neuropathy. If they present in the orbital region, they can cause visual complaints, and more worrisome, if they present in the airway, they can cause compression of the trachea and great vessels. Most common symptoms are disfigurement, motor dysfunction, pain, and less frequently the other symptoms. So it's important to consider that about 2/3 of the patient can present with at least one symptoms. And in 10% of the case, there is more than one symptoms and median of 3 symptoms per patient per neurofibroma. So they are often symptomatic. The natural history of plexiform neurofibromas changes with time, and you can see here in the blue graph, a younger patient tend to have a more aggressive behavior, whereas older patients tend to present with less aggressive behavior. And here as well in the graph, you can see this trajectory where the patient tend to lose their growth potential with age. So the plexiforms slow down with age. But in the young children, it can grow quite significantly, about 35% rate of growth in a year. So they grow slowly, but they grow with time. Radiological assessment of plexiform can be challenging, and we often need to use volumetric assessment because two-dimension or one-dimension measurement is not reliable to depict some of the variation in the structure. MRI is the gold standard for measuring plexiform neurofibroma. You don't need to give the contrast, but you need specific T1, T2, and STIR sequence to measure this lesion. And it was defined that 20% volume change was considered as significant for improvement or change progression with time. Surgical resection is the mainstay of treatment of plexiform neurofibroma. However, complete resection is only achieved in a minority of patients, and that's because it affects the vital structure, which are often highly vascularized and within the nerves. Radiation therapy is not a good option for this patient because of the risk of tumor, secondary tumor with radiotherapy. Chemotherapy is not particularly effective, and molecularly targeted agents, until recently, they were all experimental. So plexiform, which are inoperable and symptomatic, represent a significant burden in NF1 community. And you can see how the prevalence of inoperable and symptomatic neurofibroma represent a small group of all the NF1 patients, but there are still a significant number of patients in this country. The European Reference Network Genturis group has developed for the first time a guideline to help clinicians in diagnosing, monitoring, and approaching treatment for this patient. And the background, the rationale for these guidelines is that patients with NF1 do not have access to the same level of care in all countries, and treatment varies significantly. So we wanted to provide, suggest, and recommend appropriate level of care, reducing unnecessary investigation, but also recommending the useful investigation at the right time, and including supportive care, including psychological and quality of life aspects for this patient. So regarding plexiform neurofibromas, the recommendation basically suggests that clinical examination is the most important thing to monitor in this patient. If then you develop a plexiform neurofibroma, then you perform an MRI focus on that lesion. And importantly, during the transition between adolescence and adulthood, it might be useful a whole body MRI to reveal all this internal plexiform. And because the burden of disease, which can be found at the whole body MRI, can predict, and we'll see later on, the risk of this lesion to degenerate into more malignant tumors. So the surveillance is mainly clinical MRI is focused based on clinical suspicion, and the whole body has a role in prediction of the malignant degeneration. At diagnosis, the frequency of imaging, it varies and should be determined on the individual basis based on a multidisciplinary team assessment based on the presence of symptoms, the age of the patient, the behavior of the plexiform, or the radiological characteristic. Symptomatic plexiform requires more frequent monitoring to rule out what are called atypical neurofibromas or malignant peripheral neurosheath tumors. There is a role for PET scan, preferably MRI, to reduce the radiation, to rule out or to assess suspicion of a malignant degeneration, to target the biopsy in the most highly metabolic region of the plexiform. MEK inhibitor might represent a treatment option for some of the symptomatic patients, and which are inoperable. Until now, medical treatment for plexiform neurofibroma failed to prove any efficacy. And you can see how this was a trial of a tyrosine kinase inhibitor called imatinib, which has been used in plexiform neurofibromas, where only a minority of patients experienced some degree of response in the tumor. And another trial of mTOR inhibitor, sirolimus, as well, failed to prove a significant response in terms of radiological improvement. The first interesting results came from the preclinical model from the National Cancer Institute in Bethesda, where they studied mouse model with this drug, which proved to be effective at various doses, and it inhibited the MEK pathway, blocking the activation of the RAS, MAP, and ERK pathway. So going back to the plexiform neurofibroma, we know that part of this tumor can, with age and with older age, tend to degenerate into a more aggressive tumor, which are called atypical neurofibromas, which can you can see here with this more distinct nodular lesion. So radiology can help in depicting this degenerating plexiform neurofibroma with age, and they have some characteristic histological as well as molecular features. They acquire somatic mutation in other oncogene like CDK, N2A, B. So it's a progressive acquisition of mutation which makes this plexiform neurofibroma degenerate into atypical neurofibroma and further degenerate into malignant schwannoma in a minority of patients. Risk factor for malignant degeneration are some genotypes, so microdeletion in one of the area of the NF1 gene, missense variants affecting specific codons, the previous atypical neurofibroma, or a high internal tumor load on whole body MRI. Previous use of radiotherapy, as well as family history of malignant peripheral nerve sheath tumors, are as well risk factor for MPNST. Radiotherapy has been now used less and less to treat tumors in NF1, but previously it was one of the most significant risk factors to develop malignant tumors. And you can see in this PET imaging how these malignant schwannoma are metabolic avid of FDG, and this can help guiding the biopsy. And this is a clinical case of a 4-year-old girl who presents with normal pregnancy, no family history, and at 3 months present with multiple cafe au lait spots with no other NF1 criteria. Ophthalmologic exam was normal, abdominal ultrasound was normal, and no genetic testing was performed. And more recently, she presented in April this year with bilateral axillary and inguinal freckles, multiple subcutaneous neurofibromas, and a significant lateral cervical plexiform neurofibroma. The neurological exam was otherwise normal, but there was some pain at the local pressure. You can see how here these are the dyschromic region in the cervical thoracic region, and you can see here the cervical and the whole body MRI, where you can appreciate this large plexiform neurofibroma in the right lateral cervical region extending into the thorax. And notably, you can appreciate this kind of a rounded irregular contrast enhanced region, which raised the suspicion of being more aggressive or atypical neurofibroma. You can see other picture of the same scan. And so what would you recommend as the next step? So is this a patient where you need to perform surgery, you need to attempt surgery, but surgery is characterized by high risk and high morbidity? Would you go for a biopsy to rule out a malignant component in the tumor. And in terms of oncologic treatment, what you would consider, would you offer any type of the available treatment, or would you consider one of these new agent MEK inhibitors, which are now more and more available for use? Other tumors can be associated with NF1 and including myelomonocytic leukemia, pheochromocytoma, paraganglioma, breast cancer, but the most frequent tumors which involves the CNS are the optic pathway glioma, which are tumors, benign tumors, or low-grade glioma, which originates into the visual pathway, which can present with visual symptoms. The Genturi's recommendation suggests to perform visual acuity surveillance once a year until they are 8 years old, associated with fundoscopy, visual fields, OCT if that's available, and not perform a screening MRI unless you have visual symptoms, because we know that majority of optic pathway glioma do not cause problems, do not cause visual symptoms. So even with a screening MRI, if you reveal an optic pathway glioma which is not symptomatic, most of the time you won't need to treat it. And as well for extra optic pathway low-grade tumors like the brainstem or supratentorial brain tumors, clinical exam is normally sufficient for monitoring because few of them are asymptomatic. Of course, those who are asymptomatic might require more frequent surveillance with MRI. So this is again from the Genturi's group, the recommendation, and which is the most important aspect is that trained pediatric or ophthalmologists or neuro-ophthalmologists need to monitor this patient because it's a very complex and delicate condition to monitor and very specialized situation. And you need to perform age-appropriate visual testing, including visual acuity, as well as other testing is feasible. And MRI should be performed only if the symptoms are suggested. When to offer treatment to this patient with optic pathway glioma, again, progressive visual loss or visual field loss is the main criteria to decide treatment. But there are other criteria which might influence or affect the level of threshold on when to start treatment. And this probably involves the radiological aspects, the extension of the tumor to the post-chiasmatic structure, as well as the behavior, as well as the age of the patient and its behavior. So it's a complex scenario where you really need to have ophthalmologists, oncologists, radiologists all together in order to not treat those who don't need treatment, but to treat at the right time those who definitely need some treatment. And take-home message. So is the plexiform neurofibroma are a frequent complication of NF1, which need a specific surveillance and referral to specialist center. The surveillance and the referral needs to be continued throughout age as infant, children, as well as young adults, because you've seen that complication can occur at various ages. There are limited treatment options for plexiform neurofibroma, but things are now improving. So if surgery still is very limited and associated with significant morbidity, MEK inhibitor and medical treatment on the horizon seems to be very promising. However, only symptomatic or children with threatening symptoms need this medical treatment. In terms of optic pathway glioma, again, only few of them need treatment, and it's difficult to predict those who really need treatment at early stage. There are currently trials which are evaluating the role of chemotherapy versus the role of this MEK inhibitor in first line for this patient. And with this, I think I thank you very much for your attention. I'm happy to take any question if you have. And again, thank you very much for your attention.
Thank you, Professor Enrico, for this nice presentation and for Professor Enrico, do you hear me?
Yes, I hear you
Okay.
well.
Okay. Thank you for the very comprehensive and nice presentation about neurofibromatosis type 1 and about the most devastating complication of neurofibromatosis, especially to shed light about the new treatment for the inoperable case with the plexiform neuroma and affection of the nerve. Dr. Hanan Azouz will ask you. She's a professor of Neuropediatric in Alexandria University. Would like to have a question.
Thank you very much, Professor Enrico. Really, I very happy for your very illustrative lecture because we are starting neurofibromatosis type 1 clinic in our faculty. We are from Alexandria University. So it's very I am very glad to hear that there is a treatment now available, Soltinib, for the treatment of these cases. I want to ask, if we have a case of optic glioma, what is the youngest age we can treat by this medication?
So as you know, optic glioma tend to develop in early childhood, and still the standard of treatment is based on chemotherapy. So that's the main message. So if you have a young child with NF1 and optic glioma outside of a clinical trial, you should not offer this new medication. And that's very important because still the role and the benefit of this new drug compared to the role and the benefit that you have with chemotherapy is not proven yet. There are currently trials which are open in the US, which we are opening in the Europe, which will compare chemotherapy with these new agents. And hopefully in few years' time, we will be able to show that whatever works better is the standard of care. These new drugs, of course, are very attractive because they are oral medication. They don't cause the side effects from chemotherapy, even though they cause some side effects, which might be different from the chemotherapy side effect, but still relevant. And most importantly, there are very limited data about the long-term side effects of these medications. So we need to be very cautious about using this drug. We need to use in this context only if you have a clinical trial available or if you have already used standard treatment like chemotherapy. Yes, potentially, so these drugs like selumetinib are capsules at present stage. So the patient needs to be able to swallow capsules. That's why the current license in America as well as in Europe will be for children from 2 or 3 years of age. So that's the current threshold for the age limit because they might not be able to swallow the capsule before. There is currently a phase 1 trial testing a sprinkled formulation of this drug. If the trial is successful, hopefully, then you will have this further option to treat younger patients with this sprinkled granular formulation, which even younger patient could potentially take. However, again, probably at current stage, it's not fair to recommend this drug for all the children with optic glioma unless you have a scientific clinical trial which compares this medication with the standard of care, which is still based on chemotherapy. I hope it answered in part the question.
My question, what is the youngest age in your clinical trial you use this?
So the youngest age will be 3 years old.
3 years old.
Yeah, and that's because we still use the capsules.
Yeah.
Once the granular formulation will be available, it might be that we might lower down the age, like at